presentation in the background, and you'll hear the presenters over top of that presentation. You'll also have a chat box or question box in your control panel. So have a look at the bottom right-hand corner of that, and you'll see a chat box. So if you have any questions throughout the presentation, feel free to type those in there, and I'll be working in the background and pick those up. If anyone happens to have a microphone and you'd like to actually ask your question live, you're more than welcome to do that as well. You'll have to click on the hand icon on your control panel, and then that will identify you as your hand being raised, and then I can unmute you and you can speak that way. And so without further ado, here are your presenters, Dr. Samir Mao and Dwayne Cottel.
Great, thanks Steph, and thank you everyone for joining in on a lovely Friday afternoon of a long weekend. Definitely didn't realize that when we were booking this, but we really appreciate you guys being here. As Steph said, my name's Samir, and right beside me is Dwayne, and we're in for another one today. So as Steph said, we'll be talking about kind of the overlap of presentations between syncope, seizures, and cardiac arrest. Here are the main objectives of the study, pulled straight off from the flyer that was sent out. Describe the various types of seizures and their relevant anatomy, describe their clinical presentation and the appropriate management. We'll also be going through the same types of thing for seizures and managing seizures. And then lastly, we really want to differentiate the presentations of seizures and syncope and how they're related to cardiac arrest, and differentiate the myoclonic jerks that are associated with syncopal episodes from the tonic-clonic activity that people often see with seizures.
We're going to be looking at some case discussions today, and we're going to have some poll questions throughout, so you get a chance to pick your answer, and we're going to kind of discuss those and do a review of those after. We're going to do a very thorough overview of syncopal episodes, and we're also going to be talking about the different types of seizures and etiology, pathophysiology, that sort of thing related. And we're going to discuss myoclonic seizures compared to the actual tonic-clonic activities, which we'll see in the trucks the majority of the time. And then we're going to do a brief summary of everything we talked about, and time for question and answer period.
And if you guys have questions, absolutely post them online, or you can log on and save them live as well. I'll be happy to answer them throughout the presentation. So we'll start off with
chest pain. Crew arise patient is conscious, vitals are stable, aspirin's administered, he's transferred onto the stretcher, had a brief 10-second grand mal seizure, regained normal level awareness within about a minute. Upon loading the patient into the back of the ambulance, a second seizure transpired. Patient was assessed immediately, confirmed vital signs absent. Patient was in VFib, patient was shocked, a ROSC was obtained, and ABCs were maintained. So our question here, we'll give you a few seconds to take a look at this and make your choice, and you can go ahead and vote on your screen. We're looking at, was the patient's cardiac arrest likely caused by either a bronchospasm from the ASA, acute MI, seizure itself, or divine misintervention. So we'll give you guys a few seconds there.
And just to add some context, all the cases that we did sprinkle out through the presentation are all real cases from the Ontario region.
So we're looking right now, we have about 50% of the attendees that have voted, so we'll give you guys a few more seconds to do that. Okay, I'm going to close the poll now and share the results.
Okay, so our poll results, we have about 70% of people saying it was from an MI, a quarter of people said it was from a seizure, and 6 people said it was the lack of the hand of God or the hand of God. So the correct answer here was?
Seizure. It was likely from the myoclonic jerks after his heart stopped pumping blood. The patient in the previous case was actually transferred from the local emergency department to the cath lab.
All right. That's our first one. So let's start talking about syncope now. So here's case number 2. We'll start off with the syncopal case. We have a pediatric case, a 14-year-old male patient who's found by his brother with a decreased level of consciousness. Assessed to have no vital signs. CPR was assessed prior to EMS arrival. This 14-year-old patient had a history of a syncopal episode 2 days prior. Otherwise, seemed to be a healthy child, no medication use, no signs of trauma. This patient's airway was full of blood on EMS arrival. They had no shocks delivered, and the patient was promptly transported to the emergency room. So here, the most common overall presenting rhythm in a pediatric cardiac arrest is A, VT, B, SVT, C, VF, or D, asystole. And Steph will toss up that poll right now. All right, we got about half of people who have voted. Okay, so results here. The 40% of people, most common answer was VF, and actually the correct answer here is D. Peds cardiac arrests are rarely primarily a cardiac cause, if you remember back. They're usually due to something else like asphyxiation, hypoxia, trauma. So the correct answer here is actually D, asystole. In general, the EKG has, in a pediatric population, has about a 95–96% sensitivity for cardiac syncope. And here we're looking for things like Wolff-Parkinson-White, long QT, Brugada syndrome, or signs of hypertrophic cardiomyopathy. So correct answer here was D once again, asystole. All right, so let's start talking about syncope now. So here's the basic definition of syncope, where it's the abrupt and transient loss of consciousness that's associated with loss of postural tone. Now, syncope can be primarily a sign of cardiac arrest, especially in patients with organic heart disease, but oftentimes it's quite benign. Once again, it can be a harbinger of something serious. Syncope is then followed by a complete and spontaneous recovery, and about a third of the population will have a syncopal episode sometime in their lifetime. And really what's happening here is that the systemic circulation just fails to perfuse the brain sufficiently, results in cerebral hyperperfusion, and you end up getting neurological signs and symptoms before your loss of consciousness. So when this is transient, this loss of consciousness is termed syncope. Clinical features here, I have 4 things listed up here. If the patient meets all 4 of these criteria, the episode that the patient experiences is most likely syncopal. So if their loss of consciousness was complete, if their loss of consciousness was transient and associated with a rapid onset and short duration, if there was a spontaneous and complete recovery without any sequelae, and lastly, if there was a complete loss of postural tone. So once again, if patients meet all 4 of these criteria, they have a very high likelihood of having just a syncopal episode. If any one of these is missing, you really want to start evaluating for other causes. Now, in general, there's 3 basic types of syncope. We have our reflex or neurally mediated syncope, we have our orthostatic hypotension, and lastly, we have our cardiac. And I'm going to go through each of those in a little bit more detail now. So I'm putting up lists like this not to have you memorize each item specifically, but rather just understand and appreciate some of the conditions under which syncope happens. So with respect to reflex syncope, we have our vasovagal episodes. Actually, I think we just have a question here.
Yeah, sorry guys. So apparently there was a little bit of confusion with the first poll. So I'm wondering, Samir, if we can go back to the first poll.
Absolutely.
And go through the questions and answers and just provide a little bit more clarification again there.
Called EMS. On EMS arrival, aspirin was administered, had a brief seizure, regained his normal level of awareness, and had a second seizure, was then assessed to be VSA. So the correct answer here was the patient's cardiac arrest was likely caused by B and MI. Sorry if there was any confusion there earlier. So the seizure that this patient had, and I put seizure in quotation marks, was not the cause of the cardiac arrest, but it most likely was an MI. Sorry about that confusion.
No, I think that's a bit more clarification. That's awesome. Thank you.
Okay, so back to reflex syncope. So these are vasovagal attacks, or situational syncopes, or carotid sinus syncope, where you hear of elderly gentlemen, passing out when they're shaving their neck, for instance. It's really a group of conditions in which the normal cardiovascular mechanisms that are useful in controlling your circulation become overreactive. It results in vasodilation and bradycardia. Your arterial blood pressure falls, your cerebral hypoperfusion goes lower, and then people pass out. The prerequisite for having reflex syncope is that your autonomic nervous system must be functioning normally. So once again, people with vasovagal attacks, here you're going to be asking for some sort of prodrome, fear, pain, menstruation, if they were eating and had some GI stimulation beforehand. Post-exercise is also common. So these are really the more benign causes of syncope. If we go on next to orthostatic, this is where your autonomic nervous system fails to adapt to the demands of a stress because of usually decreased volume, but also secondary causes can be when there's a specific disease process affecting your nervous system specifically. So our causes here, we have primary autonomic failure, so that's something that's affecting the nervous system directly, so things like Parkinson's, certain types of dementias, pure autonomic failures, which are rare. Secondary autonomic failure is when you have some other disease process causing damage to the nervous system itself. So diabetes is a very common example, uremia, spinal cord injuries. Drug-induced orthostatic hypotension, we probably see alcohol a lot, patients on vasodilators and diuretics. And lastly, we have our volume depletion with things like hemorrhage, diarrhea, and vomiting. So in orthostatic hypotension, you have defective vasoconstriction, you get excessive pooling of venous blood in your lower extremities. When you stand, you have a profound loss in your drop in your blood pressure and a subsequent loss of consciousness. Lastly, we have cardiac syncope, and these are really the patients that we worry about because of the risk of sudden cardiac disease. Two basic types of cardiac syncope. We have our arrhythmogenic type and our structural disease type. So with our arrhythmias, we have our brady's and our tachy's, and also our drug-induced arrhythmias. And with structural disease, patients with valvular disease are at increased risk of having cardiac syncope, hypertrophic cardiomyopathy, cardiac tamponade, congenital disease, and then lastly, some pulmonary and other vascular things that can cause it, like big PEs or pulmonary hypertension can cause people to pass out. So out of all the causes of syncope, it's the cardiac ones that we're really concerned about. With respect to the general epidemiology, the cause of syncope, depending on kind of what study, what epidemiological study you read, it's often not very obvious. What we're trying to do, once again, is recognize those people in the cardiac group who are at a high risk of sudden death. The approximate distribution, depending on what you read, is on the slide. The vast majority of them tend to be a reflex or vasovagal type syncope. And the second most common disease process is actually unexplained. We don't know why a lot of these people pass out. I have 18% listed here in the case study I checked for this slide, but this can be as high as 40, 50% in other populations. Cardiac disease tends to be a smaller contributor, about a quarter, and lastly we have our neurologic and psychiatric causes of syncope. With respect to misdiagnoses, there's a number of things that can present with a partial or complete level of consciousness and no global cerebral hyperperfusion. So remember, we said in our definition of syncope, the brain, for whatever reason, isn't getting enough global blood flow. You have a drop and subsequent loss of consciousness. So these things here can cause a partial and complete LOC, but you don't have that aspect of cerebral hyperperfusion. So seizures can do it. Metabolic derangements tend to be a little more long-lasting than syncope, not quite as transient, but hypoglycemia and hypoxia are definitely on the list. Intoxication from various drugs and vertebrobasilar TIAs, transient ischemic attacks that spontaneous resolve, can cause partial or complete loss of consciousness. With respect to disorders without an impairment of loss of consciousness, we have a few listed here. We have cataplexy and drop attacks. Cataplexy is most commonly associated with narcolepsy. Patients get a strong stimulus, fear, pain, and then they have a sudden drop in their postural tone and they fall to the ground. So these patients quite often can look like a syncopal episode because they've had loss in their muscle tone and fall to the ground, but they don't have that element of impaired loss of consciousness where we can diagnose them with syncope specifically. All right, so I have to do a quick history lesson, and this was kind of interesting as I was reading for this webinar. In basic science fashion, for something to be studied, it has to be standardized. So back in the 1920s and 30s, when researchers started looking at syncope, they needed to come up with a standard, objective way to make people pass out so they could see what happened to them. So these are just some of the highlights that I saw. One of my favorites, the neck cuff, described in 1943. They took a bunch of inmates and schizophrenics, since they're not going to complain or sue, and they put this specially designed cuff around their neck, which could be inflated to 600 millimeters of mercury within a heartbeat. Stops your cerebral blood flow almost immediately, and patients would suffer a loss of consciousness. So basically with the intro studies like this, they started mapping out the initial events that happened. So first, patients would have their 5 to 6 second prodrome with visual symptoms, then have a fixed gaze, and then finally suffer their loss of consciousness. Now, I mean, these days studies like this would be highly unethical, but I guess back before ethics board existed, anything went. Human centrifuge, this was a fun one from 1946. So they took patients and the reflexes just couldn't cope. Quite often this was done in fighter jets. So the key here is that this acceleration would be absolutely rapid, so there'd be no time for the body to compensate. Military pilots would undergo 4 to 6 Gs of force for about 20 seconds. These researchers found syncope occurring at about 20 millimeters of mercury, and again they had very much of the same prodrome. Visual symptoms were the usual start with a graying out or loss of color vision, then followed by blacking out, fixed visual gaze, and then lastly a loss of consciousness. They even took this a step further. They were wondering, are the visual symptoms coming from the brain or are they coming from the retina? So when patients went through this a second time, they actually stuck these suction devices over their eyes, which would apply 30 millimeters of mercury force, and then if they did that, they found the visual symptoms would disappear before the syncopal episode. So they were coming from the retina, so that was kind of interesting. The fainting lark, this is a fun one, described in 1951. This is a good way to get out of an exam or work. I didn't actually say that, but this procedure is effective in the vast majority of the population. You squat with your knees fully bent, take 20 rapid, deep breaths, stand up abruptly, and then perform a forced expiration against a closed glottis. So if we just think of the pathophysiology here, your hyperventilation is causing peripheral vasodilation and cerebral vasoconstriction. You have a sudden shift in blood towards the lower part of the body, and then when you stand up and bear down, this straining is an impediment to venous return. So patients here would, over 70% of the time, suffer a loss of consciousness. And again, it's been used by kids and students and military recruits just for party fun or to obtain some kind of secondary gain like missing an examination. But once again, in these fainting lark studies, they describe many of the same initial steps to syncope. Rapid anoxia in 1956 put people in a decompression chamber, rapidly decompress it, and although this doesn't fit the classic definition of syncope where we have global cerebral hypoperfusion, this was more a lack of oxygen state and a hypoxic state, but it did allow study of the specific effects of a lack of O2 on the cause of syncope, and most of these patients suffered a prodrome of about 2 to 3 seconds before they lost consciousness. So I have another interesting ways that people did it here: carotid sinus massage, often the elderly, direct eyeball pressure in pediatrics, lower body negative pressure with a head up tilt. There's lots of different ways that science has figured out to do this, and as funny as some of these studies are, they were key to our initial understanding of syncope. So if we start talking about features to suggest a diagnosis, history is by all means paramount in these cases. The ones that are most likely to be neurally mediated are patients who are young and typically have a healthy heart. There's often a prodrome associated with nausea, vomiting, maybe diaphoresis, some pallor and warmth. During a meal or postprandial is also a common time for this to happen. And after exertion, not necessarily during exertion. During exertion would indicate that the patient potentially had a cardiac source. If it happens after exertion, that's suggestive of a neurally mediated course. So here the key is the prodrome that patients have. With orthostatic hypotension, things to watch out for on history. Often this will happen right after standing because we get that pooling of blood. There's often a temporal relationship with medications. If patients are on vasodilators or diuretics, their blood pressure will fall directly after taking it. And if that's when they're having their syncopal episode, then that can be a sign that they're suffering from orthostatic hypotension. And then Parkinsonism as one of the primary causes of orthostatic hypotension, just due to the damage to the autonomic nervous system that happens later on in the disease. And these patients often suffer a prodrome as well. Usually starts with visual changes, blurring, color changes, black spots, and then patients go into their syncopal episode. Cardiovascular, this is the important stuff here. People who are usually older, have a history of heart disease, family history of sudden cardiac death. This usually happens during exertion or when patients are supine. These are things to watch out for. Associated with palpitations or shortness of breath. And patients who are having multiple episodes over a short time period, and they're sudden onset with a real lack of prodrome. So that's a key with the cardiovascular syncope. There's a real lack of prodrome. And again, the the eventual course of syncope generally follows the same, with visual symptoms starting first, but these are generally so abrupt that patients don't describe the prodrome after they wake up. There's been a number of studies outlining just some of the short-term high-risk criteria for syncope. So if you're going to take anything away from this syncope part of this talk, this is really the slide to focus in on. These are the criteria that have been found to be associated with a higher degree of mortality in patients with syncope. So those with advanced age, any sort of underlying cardiac disease, whether it be structural or coronary artery disease, EKG abnormalities or arrhythmias, respiratory distress, hypotension, or a family history of sudden cardiac death. So again, there's a very wide differential for syncope, things that are completely benign to things that are immediately fatal. It's pretty impossible to rule out all of the sinister causes pre-hospital or even in the emergency department for that matter, but every single one of these patients requires a detailed history and physical with an ECG to really try to hone in on the cause. Most people will get basic labs. Some of them will even get admitted for pacemakers depending on what we find, and many that are discharged will get outpatient follow-up to make sure that they're not having recurrent episodes. With respect to pre-hospital evaluation of syncope, start with the simple stuff, ABCs. Is there a pulse? Always, always, always check for a pulse. This patient has lost consciousness, and if it hasn't fully regained by the time you got there, make sure that the patient is circulating blood. Check for equal chest rise and air entry. It's very useful if you could do complete orthostatic vitals and a finger prick glucose at the scene. And lastly, do a full examination with the real focus on signs of trauma, whether that trauma occurred before the fall or as a result of the fall. A gross neurologic exam looking for focal abnormalities. A cardiac exam, you're looking for arrhythmias, ECG abnormalities if you have that capability. And lastly, a good respiratory exam to make sure that they are oxygenating as well. So again, like I said in the previous slide, history is definitely the most important part, but the pre-hospital evaluation for the most part is fairly straightforward, but definitely don't forget the simple stuff. Pre-hospital therapy, it really depends on the patient's initial cause of syncope. I've put up some directives here that could be useful depending on the situation. The IV insertion and fluid bolus directive, the hypoglycemia directive, and then the cardiac ischemia and the tachybrady directives could also be useful. So we encourage you, if you do have ECG capability, perform an ECG on scene, do a complete set of vitals with orthostatic changes, and have these patients on a cardiorespiratory monitor so you can monitor and check for things like arrhythmias. So now I'll pass the presentation on to Dwayne to go through seizures.
Okay, guys, so we'll take a look at another case here. 54-year-old male patient, wife was unable to wake him. Found to be in seizure activity by the wife there. His vitals, pulse was 90, or respiration rate was 24, his pressure was 200 over 104, semi-conscious, GCS of 5, blood glucose was 10.6 millimoles per liter. Patient was given intranasal midazolam, 5 milligrams. The seizure terminated itself. IV was established post-midaz. Nasopharyngeal airway inserted, and the airway was maintained. So we'll just bring up another poll question here, just in regards to seizure activity. So we're looking at what is status epilepticus defined as. So we'll give you a few seconds there to make your choice. So A is an unremitting seizure. B, frequent seizures without return to baseline in between. C, frequent seizures with return to baseline in between. D, seizure associated with cardiac arrest. Or E, A or B.
All right, so the poll is closed, and the majority of people, 56%, picked E, which was A or B, which is the correct answer.
So there's lots of different different definitions, but basically 30 minutes is used to be a standard, but seizure is unlikely if it's to abort if it's on its own greater than 5 minutes.
So there used to be lots of different temporal definitions with status epilepticus. 30 minutes was what I learned early on in residency. Some of the newer literature suggests that if a seizure is still ongoing at 5 minutes, it's unlikely to abort on its own, and then by definition that would become status epilepticus.
Okay, guys, so seizures. So what are they? So a clinical expression of abnormal, excessive, synchronous discharge of neurons residing in the brain. It could be an isolated incident with no obvious precipitating cause that never recurs. Generally, they're intermittent and usually self-limiting. Recurrent seizures without any obvious precipitant is epilepsy, so more of your idiopathic. When we talk about status epilepticus, prolonged seizure or immediate recurrent without return to normal level of consciousness. So we'll talk a little bit about the history of seizures, of what they used to think seizures were many years ago. Some have claimed to be thought of these people were demonically possessed. Some would look at it and say, well, it's a type of witchcraft, and they're doing something with the spirits and that sort of thing. Some physicians thought that excessive masturbation was actually the cause, and that's interesting.
The same physicians who did the syncope studies.
Yeah. And then some of the research physicians thought it was just if somebody was feeble-minded, that was a cause of seizures. So we know now that a lot of this is inaccurate. Predisposing factors for seizure activity. So your head injuries, causing elevated intracranial pressure, producing seizure activity. Your meningitis patients, bacterial or viral. People who have suffered from a stroke. Your hypoglycemic patients, one of the big ones we have, where anyone with a decreased level of awareness, seizure activity, we're going to check the sugar just to rule out hypoglycemia. It is one of the mimickers. Hypoxemia, so the low blood oxygen, low cellular oxygen. Alcohol withdrawal, so you're DTing out there basically. Fever in children, it's generally less than about 2 to 3 years of age.
6 months to 6 years.
6 months to 6 years. And your idiopathic epilepsy, so you're having seizure activity. They don't know why. You end up seeing a neurologist. They do all the appropriate examinations, EEGs, and that's when you generally determine that the patient is epileptic.
Yeah, so that'd be more of a primary cause, where the list that Dwayne has above with head injuries and strokes and hypoglycemia, those would all be secondary causes of seizures. So again, secondary meaning something else causing badness to the brain, which results in your seizure.
And just taking into account with the seizure activities, it's usually your sodium levels drop, your calcium levels drop, fever and toxins, intracranial hemorrhage, and meningitis. They're not like epilepsy related. These are acute symptoms.
Epilepsy, by definition, would be kind of the last point there, where it's idiopathic. There's no obvious cause for the seizures found. These patients often do really well on oral anti-epileptic medications. The other causes you see here are not epilepsy. Again, those are secondary causes of seizures. So just a little bit of definitions there, but they are important when you're describing it to another healthcare provider.
So talk about the etiology of the seizure activity itself. So you have the temporary changes in the level of awareness. Then it's caused by abnormal electrical activity in the brain, usually due to the permeability of the sodium and potassium ions. Can be caused by structural lesions, so tumors in certain areas, putting pressure on certain areas of the brain, problems with brain metabolism, all the electrolytes trying to move through, and the neurotransmitters, if there's some type of blockage, can cause this. And what happens is the neuron's ability to depolarize becomes enhanced during would cause the seizure activity. So very excitable neurons.
Yeah. So and I'll have a graphic of this later on in the slide, but seizures by definition have this hyperexcitable state in the brain. You have generalized synchronous discharge of all your neurons. So I mean, this isn't technically correct, but essentially on an EEG, you see VT of the brain, just very fast, quick spikes on EEG, which indicate seizure activity, and that'll be a little different from the other movement-type disorders I'll talk about in a few minutes.
So, okay, so types of seizures. The one we're most used to seeing out in the trucks, out in the field, are your grand balls. So your full body, they're the most common one, the full tonic-clonic motions. Other ones we'll see are your petit mal or your petit mal, your absent seizures. They also say daydreaming type thing often happens in young children. Okay, focal motor, so it may start at the foot, work into the leg, work up to the upper part of the body, and progress into the other side of the body and terminate itself out. But it's localized, it's focalized to one area. It can end up going into a full grand mal seizure, though they can actually happen.
And most often you'll see these focal seizures in one of the secondary causes that Dwayne mentioned earlier. So for instance, a previous hemorrhagic or ischemic stroke, that damaged part of the brain can become a focus for seizure activity. So that's quite often when we see focal seizures, which can progress on to a generalized seizure after a few minutes.
Your psychomotor type of seizure is actually your like your pre-seizure aura. So the patient may hear something, taste something, smell something that's not there. It is classified as actually classified as a seizure. Only it's the beginning of a grand mal. And then your hysterical seizures, where somebody's at a party and for some reason they're faking a seizure, and then an ambulance rolls out there and utilize all these allied resources because, you know, hey, I want to look cool at a party, I'm having a seizure, and here we are. So
I hear cold calorics work really well to stop those seizures. No, I'm kidding. Don't do that. Don't do that.
So we're stages of our grand mal seizure. So we have our pre-seizure aura. So like I said before, so it's interesting that the pre-seizure aura is actually unique to each individual patient. A person who has epilepsy has their own specific aura, and it generally doesn't change. From that, sorry.
And an aura is a little bit different than our prodrome that we talked about with syncope. So again, our prodrome patients will start with some visual blacking out, a fixed gaze. An aura is more commonly a specific sensation, so smell, taste, sound, deja vu, for instance. So hopefully that's a little clear what the difference between a seizure aura is and a prodrome before a syncopal episode.
Thanks. Then they'll lose consciousness. They'll go into an unconscious state. They'll progress into the tonic movements, where extensor muscles, and they stretch out and they really kind of arch their back, that sort of thing, and they actually become apneic at this stage. Then they have the clonic movements, which includes like the salivation. They have the tachycardia going on, the contraction, relaxation of the muscles. That'll progress anywhere from 30 seconds to 2 minutes, 3 minutes. Let them, they'll have their seizure. Then their level of awareness is now altered again, and then they'll wake up in a postictal stupor. So it's just completely exhausted. They don't know where they are. They don't remember what's happened. Complete retrograde amnesia for the seizure activity. So some of the treatments with these grand mal seizures in the past, they actually performed trepanation. What trepanation is actually, and they still use this today for relieving intracranial pressure and intracranial hemorrhage in some cases, where they actually drill a hole into the skull that exposes the dura mater. And it was thought that by relieving the pressure, the seizure would therefore stop. And they still, like I said, they still use it today, neurosurgeons.
But not as a treatment of acute seizures. So don't pull out your drill during your calls.
Sterilization. This was actually performed during World War II by the Nazi Germany because they found that they did not want to have any offspring that were having seizures, so they just wanted to eliminate the problem right out of the bat. Bite blocks were used. That was common practice up until maybe about 15, 16 years ago to prevent somebody from swallowing their tongue. Dousing with water would stop the fit.
And I've actually heard of this being performed by lay rescuers even today. So I think some of these kind of medical myths are still existing.
And most of these people, or some of these people, would be physically restrained. Well, as we all know, we never restrain because the contractions are so forceful that they will break bones. So today we're much more humane people. There are anticonvulsant medications. In the emergent situation at Prehospital, we utilize midazolam. Our routes are very specific, so intravenous, intramuscular, intranasal, or buccal. Midazolam and any of these anticonvulsant meds are very effective for controlling these acute seizures. Relatively few side effects. The biggest one to try to hit home and always be aware of is that we always want to watch the respiratory effort. We want to make sure they're breathing on their own and that the rate doesn't become too low. So just when we're teaching or when we're taking care of our patients, right? Remember your MCP, your crew safety, maintain the ABCs, oxygenate the patient, maintain their airway, whether you're using a novel breather, whether you're using BVM to support them if they're at that state. Vital signs, blood glucose done quickly to rule out hypoglycemia. Okay, get your line started. BLS support, and then if you're ACPs in our region, we're utilizing midazolam now. And always remember, a cardiac arrest often appears like a brief seizure followed by a loss of tone, and hypoglycemia, as we said before, can result in syncope and seizure. So our directive, so active generalized motor seizure. So the only contraindication really for midaz is an allergy to it, or if they're hypoglycemic, because hypoglycemia is we have a cure for that reversible treatment. They have to be unresponsive. There's no age or vital sign parameters. So our dosing intravenous is 0.1 milligrams per kilo to a maximum of 5 milligrams, and you can repeat the dose in 5 minutes. So maximum of 2 doses. And then intramuscular, intranasal, and buccal are all 0.2 milligrams per kilo. Maximum dose is 10 milligrams, and then you can repeat that one more time.
And once again, the point of this webinar, there's if you get your directives out, there's a clinical consideration at the very end, which states conditions such as cardiac arrest and hypoglycemia often present a seizure and should be considered by the paramedic. So once again, reassess your patient after that seizure. Make sure that they still have a pulse. And if they're hypoglycemic, if you fix the hypoglycemia, you're going to solve the seizure. So make sure you're ruling out those 2 quick, important causes of seizure before you start administering midazolam.
So our midazolam itself, person, so it is a short-acting benzodiazepine. Doesn't last very long. The duration time is 1 to 3 minutes. Used for patient sedation for us and for seizure control. It can be potentiated with alcohol and barbiturates, so it's the potentiation factor, so it compounds, and it's more like a 1 + 1 = 5 as a 1 + 1 = 2, and it can be very dangerous.
And that's where you have to watch out for your respiratory depression, which is the big side effect of benzodiazepines. So if patients have alcohol or barbiturates on board, you can expect that smaller doses of midazolam will reach your kind of desired endpoint of cessation of seizure in this instance.
And the duration of it, the midaz, depending on the patient, right, anywhere between 2 to 6 hours.
It's very quick onset, which is why it's a great benzodiazepine in this case. And the duration is variable. We usually say up to probably about a couple hours. So it's not quite as long acting as diazepam and lorazepam. So that's why midaz is really a great choice pre-hospital. So now on to the last part of our presentation, which is really kind of the key, and differentiating syncope, seizures, and cardiac arrest. And this might sound silly at first, but from the slides that we've been through, you can see how there's quite a bit of overlap between the presentations of syncope, seizures, and cardiac arrest, and quite often it can be difficult to tell quickly what exactly the cause is. So we'll throw up another case here, case number 4. 59-year-old male has a sudden onset of chest pain. Initial vitals are as follows. Everything's pretty normal with a GCS of 15. Paramedics administered aspirin, but no nitro. This patient had a chest decrease in his pain en route to the ER, but then had a sudden onset of some sort of seizure which lasted about 30 seconds. This patient became unresponsive, had agonal breathing, and the medics assisted with the nasopharyngeal airway and BVM. The medics then arrived at the ER, and upon assessment in the ER, this patient was actually found to be VSA. So, poll question. As an ACP, when you first witness your patient have a seizure, your first course of action should be which? A, administer midazolam. B, perform an EKG. C, reassess patient vitals and monitor. Or D, pour cold water over the patient. So we'll just give everyone a few seconds here to answer that. All right, so we have the vast majority, 94% picked C, reassess patient vitals and monitor, which is absolutely correct. The reason I had seizure marked in apostrophes there earlier was because the seizure likely wasn't a true seizure, but rather myoclonic jerks after this patient's heart stopped pumping blood and his brain wasn't getting any oxygen.
So we'll look at one more case here. So a 59-year-old male patient woken up with shortness of breath and a possible seizure as witnessed by a partner. There was no CPR prior to EMS arrival. CPR was by a primary care paramedic crew. 2 shocks were delivered. Patient has a cardiovascular history, but it's really non-specific. No history of epilepsy. ALS directives were followed for the VSA patient, and the pronouncement of the patient was done on scene. So one more question here. So the seizure referred to by the patient's spouse was most likely A, myoclonic jerks, B, the cause of his cardiac arrest, C, due to nocturnal hypoglycemia, or D, should be treated with midazolam on paramedic arrival. So we'll give you guys a few seconds to cast your vote.
All right, so closed. We had 75% of people pick A, myoclonic jerks, 25% picked B, the cause of his cardiac arrest. The answer here is actually A, myoclonic jerks. And once again, I have seizure and apostrophe. People often use the word seizure to describe any sort of abnormal movement with a decreased LOC occurring in patients, and there really is a stricter definition of the word seizure. What happened here is that, again, once this patient's heart stopped beating, brain stopped getting blood, most likely this patient suffered myoclonic jerks as a result of the cerebral hypoperfusion. Seizures are almost never, unless patients are in a severe case of status epilepticus that we're unable to abort, are almost never the cause of a cardiac arrest. This movement disorder, or quote-unquote seizure that people describe in this situation, will almost always be a myoclonic jerk. So faint or fits. Now, seizures are easily the most common misdiagnosis of syncope just because of the movement kind of seizure-like activity that can happen after someone loses consciousness. Remember, we said earlier in the presentation that syncope is caused by global cerebral hypoperfusion. So this global cerebral hypoperfusion causes low glucose, low oxygen, other nutrients getting to the brain, and the brain responds by having these short movement-like disorders, which are actually myoclonic jerks. The seizure-like activity is often seen immediately after the onset of syncope and cardiac arrest, and that's the key here, that it happens after the patient has lost consciousness. The diagnosis of whatever movement this was really depends on a detailed history. The main difference really are the symptoms pre and post seizure, and all 3 events can look really, really similar at first, so it's important to really get a good incident history. So here's what I was talking about. Seizures cause this type of kind of epileptiform spikes on an EEG that you see here, essentially VT of the brain. Loss of cerebral blood flow from any cause of syncope can result in a seizure-like state, and these types of movements, like myoclonic jerks, because it happens with cerebral hyperperfusion, are actually associated with brainwave slowing on EEG, not these spikes that you see here. So, I mean, EEG isn't a test that you would do pre-hospital or that we do in the eMERGE, but just at a pathophysiology level, that's the difference between myoclonic jerks and true seizures. So what are myoclonic jerks? Well, they're brief, involuntary twitching of a muscle with rapid contraction and rapid relaxation. In and of itself, it's not a medical sign, but myoclonic jerks are rather a sign of some specific disease. They're not a specific disease themselves, sorry. They're a medical sign of something else going on. The most common example of a myoclonic jerk is actually hiccups, where you have a rapid involuntary contraction and relaxation of your diaphragm. Two are myoclonic jerks, which are your sleep jerks. When people are drifting off to sleep, you'll often see them jerk their muscles, and hiccups like I just mentioned. Number 2 is your secondary causes of myoclonic jerks, and again, this is the myoclonic jerks that are caused by something bad. Multiple sclerosis, cerebral infections, strokes, dementias, cardiac arrest in capital letters and underline can also be a cause. And then lastly, you can just have myoclonic jerks which are associated with epilepsy or just hereditary. In those studies I mentioned earlier, we did actually learn something by putting cuffs around people's necks, as gross as that was. Those fainting lark studies showed that myoclonic jerks happened in nearly 100% of subjects after they had their syncopal episodes. They typically lasted anywhere from a couple seconds up to about 15 seconds. And unfortunately, we weren't able to put up a YouTube video of a myoclonic jerk just because of copyright legislation. We couldn't afford it, but I definitely encourage you guys to go onto YouTube. There's some great videos on myoclonic jerks that you can find which will help you differentiate between them and true seizures. So again, these myoclonic jerks are typically not rhythmic or symmetrical, and they occur after a person has already fallen versus, let's say, in a seizure, the seizure will often be the cause of the fall. Myoclonic jerks are seen after loss of blood flow to the brain, and two big causes there, syncope and cardiac arrest. And the exact pathophysiology is unknown. We think it's related to lack of oxygen and nutrients reaching different parts of the brain, but unfortunately science hasn't been able to hammer that out just yet. So if we take myoclonic jerks, just brief contraction and relaxation of muscles, here we have a picture of tonic-clonic activity that you'll see with seizures. So tonic, meaning increased tone, Dwayne talked about that earlier. You have marked muscular contraction of your agonists and antagonists throughout the entire body, so increased tone. This is then followed by the clonic part, which is the rapid contracting and relaxation of your muscles, which is what cause your actual convulsions. So myoclonic jerks themselves, due to syncope or cardiac arrest, don't have this beginning with increased tone, and again, they occur after a person has already lost consciousness. So some factors that are suggestive of a true seizure, so a seizure due to epilepsy, for instance, patients who have a prodrome or an syncope. So again, an aura tends to be some sort of sensation, either visual, olfactory, auditory, before the seizure, not the nausea, vomiting, pallor that people experience with syncope. There's a very abrupt onset, usually associated with a true seizure, and you have a tonic phase before the clonic phase. Patients will often deviate their head and have unusual posturing just from the increased contraction of their muscle, and is one of the most specific signs of a true seizure. Incontinence is often seen in seizures, but again, that can also happen in syncope. Patients here will often have a postictal phase, and the postictal phase here with a true seizure is different than the postictal phase you might get with myoclonic jerks when the patient doesn't have a pulse and is unconscious. That is not a postictal phase. The postictal phase we're talking about here is the patient still has vital signs, still has a pulse, but is in that state where they're either fatigued or stuporous, but again, they're still alive. The decreased LOC here usually happens for about greater than 5 minutes, whereas most causes of syncope are very short-lived, and the transient nature of syncope suggests people are usually back up to their normal LOA within a couple of minutes. Here's a quick diagram just kind of giving a pictorial of the difference between syncope and seizure. So you can see the person on top who has just suffered a syncopal episode. They have flaccid tone throughout. Have muscular contractions, your head deviation, increased tone. Now, a picture is not as great as a video, so once again, I encourage you guys to go onto YouTube. There's some great videos of generalized tonic-clonic seizures that you can watch, and compare that to myoclonic. I've definitely tried my best to describe it in words, but a video will definitely do it more justice than I can. So what about cardiac arrest? This is the most important part. Often the treatment for someone who's lost consciousness, the diagnosis needs to be quick and the treatment needs to be almost immediate in a lot of the life-threatening causes. So in the instance of diagnosis and not reassess your patient and go on to hospital later on to find that they don't have a pulse. Cardiac arrest is very often, because of the lack of cerebral blood flow, likely to cause myoclonic activity. So don't be surprised if you see a patient having these So again, that's not the seizure causing the cardiac arrest, but rather the cardiac arrest causing the myoclonic jerks because of lack of blood flow. Generalized seizure activity can be seen after cardiac arrest, but really is much, much more rare. You're going to be looking for the non-symmetrical. Keep recognizing that these involuntary movements can be a sign of something really ominous, so constantly things like CPR and defibrillation are most effective when administered quickly, so this isn't a diagnosis that you want to delay or miss out on. So I'm just going to hand it to Dwayne to summarize the presentation.
So SWORBHP is very common, and cause is often not found. Okay, we talked about it's very important that identify these high-risk group patients for further investigation. So anytime syncopal episode, they should be taken to hospital and assessed by a physician, these people, and keep taking into account predisposing factors and what's going on in the scene. Remember, seizures, they can also cause loss of consciousness, but not as quick as not like turning a light switch on and off. It's not a quick on, quick off. As syncope, the seizures last a few minutes, right? And consciousness is regained within about 30 seconds to a minute. Remember that they're usually self-limited, but basic positioning and medications can help prevent any more harm with these patients. Low flow states to the brain, so lack of oxygen, rest off, lead to the often lead to myoclonic. Primary exam again, if they're in cardiac arrest, CPR quickly, pads on quickly, and go from there.
And here, you guys probably noticed, even Dwayne and I at times use the word seizure pretty liberally. You clarified that earlier. A true seizure is one in which you have generalized discharge across your entire cerebral hemisphere. So you have seizure-like activity after cardiac arrest. Those are associated with brainwave slowing, so it's not a true seizure. So, so sorry that we ourselves use seizure in the lay term sometimes, but that's not technically correct.
And patients that can help us quickly identify the difference between the myoclonus and true seizure activity. And as always, don't take the safer diagnosis. Always be prepared for the worst and go from there and treat what we find very quickly. Recognition.
All right, and that's actually the end of our presentation portion of the webinar. So thank you very much for listening in. Please fire them away to Steph, and we'll do our best at clarifying anything that we didn't during the presentation.
So if anyone has a question and they have a microphone attached to their computer, we're more than happy to take you to speak live on the webinar if you'd like. So in order to do that, you have a hand symbol on the left-hand side of your control panel. So if you go ahead and click on that hand, it'll show me that you've raised your hand and that we can unmute you and you can talk over the webinar if you do have a question that way. Otherwise, the question box where you can type in questions is still open. I don't have any questions right now, so I'll maybe give you guys a few more seconds to maybe come up with some. So it doesn't look like anyone's putting their hands up or typing any questions, so I guess we'll call it a close then. Huge thank you to both Dwayne and Samir for another great presentation, very informative, a lot of detail in this one. So once again, thank you to them for the presentation, and thank you to everyone for attending on a Friday webinars or presentation. So thanks again. Take care, guys.
Have a great long weekend, everybody.